what did I do to this patient? Why does she look so crazy right after surgery? Why are her eyelids sutured shut? All these questions would come to mind when you see this post-op photo. So this patient, you can see in the top photo, she had surgery by some famous people who did a very aggressive upper blepharoplasty, lower blepharoplasty, brow lift. She's had fat grafting misplaced in the wrong places, bunch of filler that's migrated, a lot of issues going on. But the biggest problem, you can see how bloodshot and red her eyes are. That's because she can't close her eyes all the way. Her lower lids are pulled down and they have very little mobility to them. They're kind of fused down. There's not enough skin here. It's a very tough situation. Lower eyelid retraction is one of the toughest things to fix because, again, I spent a lot of time on this procedure. I think I did everything right, but now what's unpredictable is how is she going to heal? How is this tissue going to react when we're going in? We're cutting through a lot of scar tissue. We're trying to put things back up to where they used to be, doing a lot of maneuvers and hope things heal in the right place. So we tried revising her brows a bit. I don't know how much they're going to come up because that deep temporal fascia that we kind of glide on when we do an endoscopic brow lift was completely gone, torn up. These old implants that they had put into the bone had kind of fused into the tissue. It was tough to get into the right tissue plane. We use that same endoscopic approach, just like when we do our cosmetic sort of ponytail style lift. That also comes in handy for these cases because we're able to lift the cheek up and push some more skin up to the lower lid. And in a lot of cases, I can avoid using a skin graft because I'm able to recruit more skin here. So this serves a double, triple purpose of giving us more skin to work with, helping support the lower lid because we're able to lift the cheek and lift the orbicularis muscle from here, which gives more lower eyelid support. And also it just cosmetically looks nice to have higher cheeks and stuff. So it's a win-win-win in that scenario. And we get to avoid a skin graft, which doesn't always look great post-op. We had to do a canthoplasty. We had to actually, in these cases, when we are cutting and repositioning the tendon of the lower lid, we're doing a spacer graft. So we go in through the inside, release all the scar tissue there, and then we put in a spacer graft. I used an umbilical stem cell cord graft to give more length and support to the posterior part of the lower lid. For the upper lids, we had to go through, release a bunch of scar tissue that had scarred down to our levator, attempt ptosis repair to get this right eye and left eye a little up and matching. But the problem is we can't open things up too much because she already can't close her eyes all the way. And same thing with her brows. We can't really lift them up to where we want to be because too much upper eyelid skin has been removed and the muscle's been removed. So her blink is really weak. So this is one of those scenarios that, yes, we want to make things look better, but the primary goal is to help this patient feel better. So she doesn't have to constantly wear specialty contact lenses, keep drops in her eyes, fill her eyes with ointment every night because her eyes are so dry. It's messing with her vision, it's putting her in chronic pain. So it's function first, form comes second. Obviously, the form is going to improve in an attempt to improve the function, but some things we just can't get to exactly where we would ideally want them to because we're a little past that point, and that's not the priority here. So we'll see how she heals. I'm kind of updating you guys in real time about this because I think it's going to turn out great, but you never really know. And a lot of times these cases need 2 or 3 attempts and little tweaks afterwards to get right. And so I would not be surprised if we had to do a second round of probably smaller tweaks, but smaller things in a few months and so forth. Last thing I forgot to say, if you know someone with lower eyelid retraction that's dealing with these functional issues and cosmetic issues, make sure they're getting collaborative care with an ophthalmologist or optometrist who specializes in dry eye and surface issues, as well as oculoplastic surgeon or plastic surgeon, facial plastic surgeon, someone who can repair lower eyelid retraction. Because, luckily, since we have an eye center and a cosmetic surgery center, we have doctors like Dr. Prabhakaran and stuff who know a lot about dry eye treatments. And the problem is once the cornea is exposed for so long, these meibomian glands get all trashed up. There's lots of multifactorial things that are contributing to the dry eye. So that needs to be treated as well as, but we do need to, those treatments aren't going to work until we get things into the right spot either, right? So we got to do both. Obviously, most importantly, we got to get these eyes to close all the way, right? But But yeah, there is hope. There are solutions, especially to make you feel better and look better. So, but make sure you're getting that collaborative care, either with someone who does both or a place that has multi-specialty involvement or collaborating person to work with.